It's always difficult. Thank you to Rabbi and the local organizing committee. It's always a pleasure to stay with you. It's always difficult to speak after wonderful images by Bernard Benoit, especially on the same topic. I will try to cover the issue of craniofacial abnormalities, mainly basing my talk on the second trimester when the mid-trimester anomaly scan is carried out. Why talk on craniofacial abnormalities? Because there is still today a low detection rate, because the syndromic risk is very high also for apparently isolated lesions. And this is because in some cases you may only have a craniofacial abnormalities as a possible sign of an underlying syndromic condition in which there is also mental retardation, and because there is also a very high aesthetic impact also if isolated. Let's think about, for example, microphthalmia. If we stick to our guidelines, you are bound to see the lips, tangential view of the lips, and the orbits, and if feasible, the profile view, mid-sagittal view of the profile. So first, let's talk screening-wise. So we try to see what kind of abnormalities we may suspect by using these two views, and then we will expand on the, I would say, the expert evaluation of the fetal face. So let's start from the binocular view here. And of course, you can see abnormalities of the orbits in the sense that the interocular distance may be reduced, such as in hypotelarism, and various degrees of hypotelarism, or it may be increased in hypertelarism. You may have a missing orbit or a very small orbit on one side and not on the other, or on both sides, and that's consistent with diagnosis of microphthalmia or anophthalmia. And then you may detect abnormalities of the lenses, such as cataract. If you use the tangential view of the lips and nose on 2D, then, of course, this is meant to detect unilateral or bilateral clefting, such as these ones, and also very rare abnormalities of the nostrils, such as these single nostrils, which is usually found in association with holoprosencephaly. And I think Gianluigi will cover this issue as well. Having said that, when we suspect this type of abnormalities, we refer the patient for expert opinion, and so you need a more thorough and comprehensive approach to the assessment of fetal face. And with the brilliant images by Bernard, you see that we may usually use an actual approach to see most of the structures, anatomical structures that can be seen on the face, face of the fetus. So we'll try to see all the abnormalities in this way, and we start with this kind of scroll from the frontal part. Then you see the two orbits. This is much more easy with the volume because the fetus will not move across your evaluation. So you just get the volume, acquire a volume, and then scroll your volume and navigate your volume. You see the lenses here. You see the nasal structures in the middle. You see the cheeks and the zygomatic arches here. And then the alveolar ridge with an intact upper lip. The tongue, or pharynx, the two rami of the mandible here, the lower alveolar ridge, and the tip of the bony mandible, and the symphysis mentis here. So by using this type of approach, you have an adequate cover of all the anatomical structures of the face, and so we may start assessing all the abnormalities at different levels. Let's start with the most severe comprehensive derangement of the anatomy of the face, which is consistent with autocephaly or agnesia. It is also called agnesia because the jaws are absent. And you see here that the most prominent features is that the two ears are just in this position and almost touching on the midline. And these are two cases in 1 hour and one by Rabbi published in the White Journal. It was also a picture of the month, I think. Let's get rid of all midline abnormalities at all levels because they are part of the holoprosencephaly sequence, and so we expect that you will have already assessed the brain and found out the major abnormalities, which is the holoprosencephaly. So all the different midline abnormalities of the fetal face are less relevant for our everyday practice because usually you come to evaluate the face after having assessed the brain properly. So in this case, you will have all degrees of hypothyroidism, which in the overwhelming majority of cases are associated with holoprosencephaly. You see here severe hypothyroidism or two eye bulbs in the same socket, or cyclopia, and these are the corresponding specimens, and this is a frontal view. The same things regards the nose. You know that you may have the proboscis with absent nose, or you may have complete absence of the nose, the nose here, and this is a 2D and 3D and the specimen after termination of pregnancy, and the same single nostrils I showed you before. And also regarding the lips, if you have a median cleft of the upper lip, that in the overwhelming majority of cases is associated with the holoprosencephaly. There are very few syndromic conditions, one I'll show you later on, which are in which you may find a median cleft. So let's start with the other abnormalities, which are more relevant because these are not associated with the holoprosencephaly. Let's start with the orbits, of course. And if you have an increased interocular distance, this is consistent with diagnosis of hypertelorism. This is the distance, and you know you measure usually the binocular diameter, the very nice chart resisting the years published by, I think, Philippe Gentil. And you may have hypertelorism for two different reasons, either because there is a mechanical obstruction in between, so the two eyes that are quite wide apart in embryonic part of the development cannot move one towards the other because there is something in the middle that prevents this movement, and this is in frontal encephalocele consistent with the diagnosis of frontonasal dysplasia. And you see here that this is one of such rare occasions in which you may have an association with the median cleft of the upper lip. Or you may have an increase in interocular distance without apparent mechanical obstruction, but you see there was a lot of fluid here. This baby had fixed, extended fingers all the time, and polyhydramnion, so was not moving, and this was consistent with diagnosis of restricted dermopathy, which is just a step behind the actual ichthyosis that you may be more familiar with, and also Bernard Benoit showed very nice images of a recurrent ichthyosis in his experience. Bear in mind that since you have symmetric organs on the face, your alignment of the transducer should be quite perfect, because otherwise you may create a false, an artifact and create a false positive impression of microphthalmia, which is not the case. If that's the case, you just realign your transducer with the two orbits, and you see that there is no, that the volume of the orbits is quite same on either side. Then you may have an abnormal sides of the orbit or the eye bulb within the orbits. Very commonly in trisomy 18, but there are several conditions which may be associated with microphthalmia or anophthalmia. This is one case of trisomy 13. You see also the bilateral cleft lip and palate, and you see how small are the orbits. You don't need even to measure them to find out that it had hypothyroidism and microphthalmia at the same time. Bear in mind that this is a spectrum, and it's also an evolving lesion. So in the next slide, I will point out that you may find out also late onset cases of microphthalmia. Sometimes these are unilateral, maybe due to teratogenous intake from the mother during the early phase of the first trimester. There's been an association reported with hyperthermia of the mother during the early phase of the development. So try to keep below 38 degrees the temperature of the mother with nimesulide, not nimesulide, but other medication early in pregnancy, because otherwise you may have a cataract and microphthalmia at the same time. And this is a late diagnosed case in which you have an anophthalmia in a fetus which is quite normal for the rest of the baby. And don't be misled by the normal baby facing, because unfortunately in this case the mother had a lot of pictures with a very nice image of the face, but the guy unfortunately was not able to detect that the eyelids were actually sealed because there was no eye bulb inside, no eye socket inside. And this is the poor neonate at birth. Unilateral microphthalmia should be kept in mind when you are assessing a condition in which you may have asymmetry of the field of phase, such as the oculo-auriculovertebral spectrum or Goldenhar syndrome, as it was formerly known. Because in this condition, you see here, you may have an involvement in hypoplasia of half of the face of the fetus, and this is the specimen. In this case, there's also an hypoplasia of the same side of the cerebellar hemisphere. This was one case we published, and it was one by Paolo Volpe, and you see here there was unilateral involvement of the orbit here. And this is another case. You see the multiplanar imaging again is very useful because you see, of course, the profile is unremarkable because it's a lateral organ involved. So the profile is normal, and then you put your reference dot where the eye is not seen, and you see on the coronal view and on the axial view the absent orbit in the third trimester. And this is the corresponding rendering, and you see here the winking baby here, which was due to the absence of the orbit here. Keep in mind, as I was telling you before, that there have been reports published in which there have been diagnosis of microphthalmia in infants with well-documented unremarkable ultrasound in the mid-trimester. So this means that microphthalmia can be a progressive, late-onset condition. We do not know why yet, but this is quite important because for some medical legal litigation, this is of key importance to demonstrate that your mid-trimester scan was unremarkable, and you can also, of course, attach your images. If we move forward for the orbits, we have the cataract, opacity of the lenses. Also, it may be associated with some syndromic condition, but also with some infection. In this case, it was a recurrent case of Walker-Warburg syndrome in which there was not the known hydrocephaly or lissencephaly because it was in the second trimester, but still the only sign of a recurrent Walker-Warburg syndrome in this case was a bilateral, quite clear evidence of cataract. And remember that in the cases at risk because of congenital cataract, it has been shown in the literature that if the opacity is visible in the fetus, then the cataract is there. If the opacity is not seen, it doesn't mean that that baby is not going to have a congenital cataract. You see here other evidence of cataract in congenital infection. In this case, was a case of unknown rubella infection during pregnancy. And you see here that in this case, we had a cataract. We had evidence at the level of the brain. You see this strands of fibrin and the double halo here corresponding with the viral infection of the brain, encephalitis. And at the same time, there was the right outflow tract of the heart, and you see that the pulmonary valve was not opening correctly, and this was an evidence for moderate pulmonary stenosis from inflammatory reaction of the valvular tissue at this level. If we move to the ear, we have seen wonderful images by Bernard Benoit before. Usually, they are very rare abnormalities, the obvious ones, but the most important ones are probably the preauricular tags, because this cannot be mistaken for the normal spectrum of variation in the appearance of the external ear. And you see here how it was quite challenging to find out these tags in the pre-3D era, because it was quite difficult to get a lateral parasagittal view of the ear. But now, with the use of 3D ultrasound, you can actually have a very nice depiction of the details of the external ear, especially in the third trimester. And there have been two diagnoses which can be supported. The first one is that the low set ear, because in this case you have on the same image the nose and the ear, and in normal cases the upper margin of the ear should be at the level of the eye and not the level of the nose. And all these three babies have low set ears, in addition to an abnormal face. And of course, the diagnosis of preauricular tags is quite straightforward in this case, and you see images from our series and in the literature that you can download depicting the presence of a preauricular tract. What about the nose? The nose, actually, I will speak about 3 conditions: the hypoplastic nasal bone in the second trimester, very rare condition, Binder anomaly or Binder phenotype, and let's say a small nose, because we got rid of the HPE-associated midline abnormalities. What about the small nose? It can be if you have found out other abnormalities, of course. Otherwise, you will find a very small nose in half of the population of the Earth. But if you have found out other abnormalities, then an abnormal profile with a small nose will make a difference in pointing you to the correct diagnosis, such as in this case of Pallister-Killian syndrome, or on another case, if you have a mid-face hypoplasia consistent with diagnosis of Binder phenotype or Binder abnormality, you should consider that this is a benign condition, unless in the 3rd trimester you may find out the evidence of stippling of the epiphysis of the bones, which is consistent with diagnosis of chondrodysplasia punctata. I wouldn't say the most important, but most relevant in our everyday practice evidence is the assessment of the nasal bone also in the 2nd trimester. You know that Afro-Caribbean and Asian population have a higher incidence of absence of the nasal bone in associated with a normal karyotype. But you also know that if it's absent in Caucasian, especially Caucasian race, ethnicity, the likelihood ratio for Down syndrome is very, very high in the 2nd trimester too, and the cutoff for defining hypoplastic nasal bone in the 2nd trimester is around 4.5 to 5 millimeters if taken with a proper 90 degrees approach, as was taught us by Kypros Nicolaides for the 1st trimester. Let's move downwards for cleft lip and palate. 2D makes a screening. It can also make a diagnosis with some difficulties, but also the expert assessment with 2D can get all the information that you may have in the majority of cases, I would say, and 3D will increase the confidence in reaching the final diagnosis and make life easier and faster, because you will not have a moving baby around, but you just take a volume with during a period of quiet absence of movement of the fetus, and then you assess it thoroughly. And you see here a unilateral cleft as seen on 2D images with the coronal view here of the clefting and the tangential view, and the alveolar ridge evidence of the abnormality. And this is a bilateral cleft with 2 clefts here. This is a coronal view and the specimen after birth. It is not it is quite important to make a differential diagnosis of cleft lip versus cleft lip and palate, and this is a case of unilateral cleft lip that you see here with an inked ridge here, consistent with this 3D rendering, or on some other occasions you may have 2 small tags here without any involvement of the primary or secondary palate here. And the difference is important because, as you see here from the literature, bilateral cleft lip has a higher association risk with chromosomal abnormalities than unilateral cleft lip and palate, and especially versus unilateral bilateral cleft lip, isolated cleft lip. This is quite important for us to consider. 3D assessment of the normal or abnormal evidence of the lip and palate relies on the approach that Benoit has shown us before. So if you put your reference dot, for example, in unilateral cleft with a straight alignment of the face on the 3 orthogonal planes, and then you put your reference dot within the clefting on the actual view, you see the coronal plane on the other panel here, and you see very nicely unilateral involvement of the palate, and the same applies with bilateral clefting here. This is the actual view. You put the dot inside, and you have the central defect of the hard palate as well. We may use the very same volume for renderings and for better communication and understanding with the patient and with the plastic surgeon for the multidisciplinary counseling, prenatal counseling. And you see here the very same volume showing the external aesthetic impact of the disease in the 3rd trimester, and the confirmation of the extent and involvement of the hard palate here. And this is bilateral clefting I showed you before. And this is, these are the corresponding specimens, the neonate and the specimen. And this is another case of isolated cleft lip associated with an abnormal face and a tag here. Bilateral cleft lip is the only type of clefting of the face which is associated with an abnormal profile, and this is due to the fact that the median premaxillary process cannot merge with lateral ones during development of the maxilla, and this is why you see this additional tissue here on the philtrum just below the tip of the nose. And this is another case, this was a trisomy 13, and you see how large was the abnormality of the profile with the additional tissue on just below the nose and some degree of micrognathia probably at the same fetus, and it was another abnormal case. All showing this protrusion of the premaxillary process and this additional tissue on the philtrum here. And finally, the mandible. The mandible is very important for you to assess. You should actually, formally, you should differentiate micrognathia versus retrognathia, where the former points to the size of the mandible and the latter refers to the position in relation to the maxillary, but in most of the cases you have both at the same time, of course. Don't lose your eyes in looking at these tables. These are only to remember you that you have 4 groups of syndromic conditions that can be associated with micrognathia. Primary dysostosis of the mandible. You may have chromosomal syndromic condition, skeletal dysplasia, and non-chromosomal syndromic condition. A long, very long list of abnormalities. If you put this, you run this search into the OMIM website, you come out with hundreds of hits, and this is why diagnosis of micrognathia is very, very important. It may be, of course, severe, as in this case or in this case, or it may be moderate and even challenging for you to consider whether a single baby has or does not have moderate micrognathia. We have shown that the most severe degree of micrognathia is found in primary dysostosis, whereas all other 3 groups, namely chromosomal abnormalities, non-chromosomal syndromic conditions, and skeletal dysplasias, are associated with less degree, more moderate degree of micrognathia. If you have a very severe case of micrognathia, there is no problem in making it out on the mid-sagittal profile view of the fetal face. But if you have moderate micrognathia, then you may wish to substantiate it by using some indexes or some angles that can be measured. There are a lot of publications in the literature over the last 10 years, 10, 15 years, showing you different methods for assessing this. We have evaluated all these at the time we wrote that editorial that you've seen before, and at that time, probably the 2 most reliable, more reliable ones were the jaw index that you see here. You take the actual view of the bony mandible, not the alveolar ridge, the bony mandible here. You trace the lateral diameter, and then you measure the anterior-posterior one, and then you have a ratio between the anterior-posterior diameter of the mandible and the BPD to normalize for gestational age. And then a cutoff less than 23 is able to detect most of the cases of moderate micrognathia, at least in our experience. The advantage of this approach is that it can be done when the profile view is not obtainable because of unfavorable fetal position. The disadvantage is that it requires a perfectly ventral approach, because otherwise, if the baby is tilted on either side, one hemimandible will shadow the other one, and so you're not able to measure it. The other approach we found very useful was the inferior facial angle, described by Rotten and Revaillant some years ago, and it is taken in this way. I don't know whether in the latter part, in the background of the audience, you may see actually the measurement, but the first line is taken here. You see the green line at the level of the nasion, orthogonal to the forehead, and the second line is taken here from the chin to the most prominent lip, the lower or the upper one. In this case, it was some 30 degrees, you see here, It was a clear-cut case of micrognathia. And in this case, the advantage is that it is measurable also retrospectively if you have a software for doing this type of measurements on screen, also stored to the image. On the other hand, the disadvantage is that you do need a mid-sagittal view of the fetal profile to make this measurement. Some abnormal condition involving the mandible, in this case was an orofacial digital syndromic condition. You have several other abnormalities, ACC, abnormal gyration, interhemispheric cyst here, moderate micrognathia, but then you look into the OMIM website or on the Smith textbook for abnormalities, and you see that in this case you may also have a bifid tongue, and you actually look for the tongue, and you see here the indentation of the tongue here that was confirmed after termination on the specimen here. Another case of cerebrocostomandibular syndrome in which there is severe micrognathia that you see here, no doubts about that, a blade-shaped thorax and a costovertebral gap that was demonstrated here on the posterior approach with tridimensional view. And also the group of what are today called synaptopathies today, abnormalities of the neuromuscular interface, the most common of which is fetal echinacea deformation sequence, in which you have a complete paralysis of the whole fetus, all muscles across the body. And this paralysis involves, of course, the masseter, and this is why these babies do not develop the mandible here, and in later gestation they may also have microstomia because also the orbicular muscles of the mouth are paralyzed. And this is the most severe type of this group of abnormalities, which is New-Laxova syndrome, as severe other abnormalities, and in addition to them, also a clear-cut micrognathia as well. So for micrognathia, how to make a prognosis? Look for associated abnormalities to try to define whether there is a risk for non-chromosomal syndromic condition. Karyotyping is indicated especially if other abnormalities are present, because if it's a apparently isolated lesion, you should take into account Pierre-Robin anomaly and other primary dysostosis. These, of course, are not diagnosable through a karyotype. And consider Pierre-Robin only if micrognathia is isolated, and you find out at the same time on the mid-view of the fetal profile glossoptosis. But keep in mind that in literature, it has been shown that in most of the cases of apparent Pierre-Robin, at the end of the day, most of them have other syndromic condition associated, and so these were not a final diagnosis as isolated Pierre-Robin. Keep in mind that most of the non-syndromic condition and primary dysostosis involving the mandible may have autosomic recurrent recessive inheritance trait. So this is quite important for you to consider, because this a detailed autopsy should be warranted to assess the risk of recurrence in this case. And finally, microglossia. It may be moderate, in case of trisomy 21, but of course we did not use this finding to finalize our diagnosis, or in Apert syndrome, for example, as you see in this case. But the most clear-cut abnormality in which you may find microglossia is the Beckwood-Widman syndrome. Usually it is a late onset sign. You find out in the early third trimester. And you see here the tip of the tongue protruding in between the lips. And this is the 3D rendering with the tip of the tongue showing here. But of course, you have to find out other abnormalities such as omphalocele or visceromegaly. These are two large kidneys in the same babies supporting this type of diagnosis. And finally, the last slide for you to summarize what we've seen so far, because the fetal profile view, in addition to provide you with a very nice view, insight into the brain of the baby, and this is quite important because facial abnormalities are very often associated with brain abnormalities, but also it's a kind of summary of all the possible abnormalities of the face that we mentioned so far, involving at least the midline, because, for example, of course, microphthalmia cannot be detected on this view. These are all some of the possible abnormalities of the fetal face, involving, of course, the slanting forehead in case of microcephaly. And as far as this talk is concerned, the conclusion that we may draw together is that craniofacial abnormalities are indeed severe abnormalities that may point out to an underlying presence of syndromic condition in which the prognosis may be very, very poor. Current diagnostic possibilities allow an accurate differential diagnosis in most of the cases, and this is one of the districts in which 3D may help us also in screening, I would say, because once you've acquired your volume, you may scroll within it and make your life more easy, and you are maybe more confident in ruling out any diagnosis, but especially in expert assessment. As I was telling you before, there's a strict relationship with the brain abnormalities, and so whenever a facial abnormalities is detected in a fetus, the following steps should be carried out: a thorough assessment of the CNS, neurosynology, a detailed search for possible syndromic markers, maybe subtle to find out, such as polydactyly or other abnormalities involving several districts, and of course an adequate prenatal counseling pointing to whatever syndromic condition that may be associated with this condition. And I thank you very much for your attention.